Good afternoon. We should get started. This session is about Tourette's and OCD and possible pathophysiological mechanisms. We're going to be talking about clinical matters, the pathophysiology of Tourette's and OCD, and some epidemiology and some genetics, and neuroimaging. So it's really meant to be integrating several disciplines in order to understand the pathophysiology of a disorder. We're going to start with myself, then continue with Paul Lombroso. We're both at the Child Study Center at Yale. Then we'll continue with Kerstin Plessen, who's going to be talking about the neuroimaging in Tourette's. And then Matt State could not come for family reasons, so Jim Leckman is going to be talking in his place about the genetics of Tourette's. And then Jim is going to continue about the very interesting topic of oscillations and possible meaning for this disorder. So I'm just going to get started so we don't go. Oops. Okay. So Tourette's syndrome, just a few slides on Tourette's and the clinical phenotypes. As you know, Tourette's involves both motor and vocal tics, premonitory urges, we'll talk about that in a second, has its onset in childhood, usually between age of 3 to 8, and it affects actually quite a large number of children, between 0.5 and 3.7% of children have a disorder of the Tourette's spectrum. It's highly comorbid with OCD in approximately 30% of the cases, and has typically a course that waxes and wanes, that is, it's with recrudescences and then partial remissions. And in about 2/3 of the cases, it will improve with age. So by early adult, a patient may be almost entirely free of symptoms. And incredibly enough, we really don't understand or understand very little about either why somebody may develop Tourette's or why somebody may actually improve. What are tics? They're actually normal movements, things like blinking, clearing your throat. So they're essentially normal in their quality, but they are performed in an inappropriate context. So typically in a time when the patient doesn't necessarily want to perform them, and in a repetitive fashion. So they're stereotyped, they're purposeless, and the critical thing is that the person is compelled to perform them, often in order to relieve some internal anxiety or some internal urge. So because of these two characteristics, the feeling is that Tourette's probably represents a motor as well as a sensory disturbance, because the patient has an internal feeling that tells them that at that moment they should be performing a tic. And when they do that, there is a temporary relief from their anxiety. So it's a very fascinating mingle of motor, sensory, and cognitive components. So is it really a voluntary or an involuntary disorder? And this is actually a big question in the field. I'm just going back instead of going next. We still don't know the etiology of Tourette's. There is a strong genetic component, but as in many complex disorders such as autism and depression and hypertension, there are probably several genes involved, each one of them with a small effect. And also some environmental factors, including perinatal injury factors that affect the etiology of Tourette's. So I'm going to go and continue about our studies on the neuroanatomy of this disorder. We focused on the basal ganglia in our neuroanatomical studies. And the reason why we did that is because already neuroimaging studies performed at Yale and in other institutions had already shown that there is a reduction in volume of certain regions of the basal ganglia. And this reduction in volume is typically small, in the range of 5%, but it's very consistent. It was detected in hundreds of patients. So there is a reduction in volume of the caudate in both children and adults, and a reduction in volume of the putamen and globus pallidus in adults only. These are regions that are sitting very deep in the brain. This is a cross-section of the human brain. You see in green the putamen, and in orange and red the external and internal segment of the globus pallidus. They sit right underneath the cortical mantle. And they contain certain types of neurons. Some are projection neurons, that is, they project between one nucleus and the next. So they interconnect these nuclei with one another. And also some interneurons, that is, they are small cells that sit within each of the nuclei. And there are 4 kinds of those. Some are cholinergic, that is, they secrete acetylcholine. And the other 3 are inhibitory. They have GABA as the neurotransmitter, and they inhibit the other cell types. What do the basal ganglia do? What's their function? They are relatively small nuclei, but they are interconnected with essentially the rest of the brain, particularly the forebrain. They receive from many cortical areas, including the limbic cortex, which regulates emotional functions, prefrontal cortex, executive function, sensory motor cortex, hippocampus, amygdala, and also from mesencephalic regions, which have serotonin and dopamine that are important for motivation. They project to the thalamus, which in turn projects back to the cortex. So they're thought to be areas that integrate both motivational factors, which are provided by the dopamine and serotonin cells, memory in the hippocampus and amygdala, and information from the whole cortical mantle, which includes sensory motor information, limbic information, and executive functions, in order to tell us what should be doing next. Shall we do a movement or not? Shall we walk? Shall we sit? Shall we try to go to sleep? So it's an essential, important part of the brain. Within the basal ganglia, here you see the areas I was showing you before, the striatum, the substantia nigra, the globus pallidus, another area called the subthalamic nucleus, and the output area, which is the internal segment of the globus pallidus or substantia nigra reticulata. So they are interconnected by mostly inhibitory cells. You see the inhibitory cells, they are in black. The excitatory neurons are in red. They receive from the cortex an excitatory input, and there are 2 pathways. The striatum receives from the cortex and has 2 pathways that are called the indirect and the direct pathway. The direct pathway is made by an inhibitory cell, an inhibitory projection neurons, that directly projects to the GPI, which in turn projects an inhibitory neuron to the thalamus. So if this pathway is activated, say by the cortex, it will inhibit an inhibitory cell, so eventually it will activate the thalamus, which will activate the cortex. So it's thought to be a pathway, I'm going to fall down, that will promote initiation of movements. And that explains why in Parkinson's disease, patients have difficulty in initiating movements. The indirect pathways does exactly the opposite, because now you have an inhibitory cells which inhibit these cells, which in turn inhibit the subthalamic nucleus, which excites the GPI. So if you put all together, you'll find that this pathway does the opposite of this. It tends to slow down to enhance the action of the GPI, which will put a brake on the thalamus and tell somebody, okay, you should rather hold on. What does dopamine do? So dopamine will activate the direct pathway and inhibit the indirect pathway. See, by doing that, the dopamine will activate this and inhibit that, so will tend to facilitate movements, and that again explains the symptoms of Parkinson's disease. So dopamine may actually be an important pathophysiological mechanism in Tourette's. First of all, we know from some neuroimaging studies that the dopamine, the people have detected an increased release of dopamine in certain nuclei of the basal ganglia. And also we know that dopaminergic D2, right here, inhibiting drugs, can be of help for these patients, suggesting that maybe there is an increased release of dopamine in this region in certain patients with Tourette's. So again, dopamine will activate this, inhibit that, resulting in an activation of the pathway. Okay, what do the inhibitory interneurons do? Well, they're sitting up here. They receive from the cortex and will silence the striatum. So they tend to put a brake on the system, and it's thought to be that they affect both pathways, particularly the direct, and so it will tend to decrease movement initiation. So until a few years ago, there were no studies examining in a quantitative fashion the possible abnormalities in the cells that are present in the basal ganglia. So we asked these questions, and we work with the Tourette Syndrome Association that is organizing a brain bank for patients with Tourette's, and we obtained some postmortem human brain of Tourette's patients that had died and had donated their brains, and compared them with control brains. This is the list of subjects, and these are the controls. Some of them were obtained at Yale. These are the Tourette's patients. Up to now, we could only examine 4 cases, and we have more, hopefully, that we can use to confirm the finding. An important finding we saw from the very beginning was a decrease in the inhibitory neurons, which I showed you before, the small neurons in the striatum portion that tend to put a brake on the striatum. They were strongly decreased in all 4 patients in comparison to the normal controls. These are the Tourette's, these are the normal controls. There is a 59% decrease, statistically significant, in the caudate, and also a decrease in the putamen, which was also significant but less so. However, there was an increase in the same parvalbumin neurons in the globus pallidus. So it looked like as though there was an altered distribution of these cells in different segments of the basal ganglia. Now, because the caudate, you remember, in neuroimaging studies was shown to be slightly decreased in volume, we focused on that region because we thought that might be an important clue to the pathogenesis of Tourette's. And we reasoned that perhaps we should look at different segments of this nucleus. This is the caudate, shown in schematic outline in a sagittal section, that is, this is the front and this is the back. And it's like a, almost like a donut, a partial donut. This is the anterior part, this is the posterior part, and this is the putamen sitting kind of inside it. Now, the interesting thing is that the anterior part of the caudate, also called caudate head, receives from prefrontal cortical regions. The whole caudate actually receives mostly from associative cortical regions. These are the regions of the cortex that are not directly involved in sensory motor information, but they are involved in the further elaboration of inputs. So we felt that perhaps we should look at whether this decrease in inhibitory neurons was more pronounced in different regions of the caudate. So when we compared head and body of the caudate, we found that the head was more strongly affected, and the body showed more variability, even though unfortunately we could only examine 3 of the 4 patients, and became non-statistically significant. This is an example of these small neurons that we're counting, And we're counting, I should say, using stereological methods. This is a method that is unbiased. It's relatively new, and it allows us to do a statistical sampling of this region. That is, we count cells in a systematic fashion, in an unbiased way. We don't decide where to count. We do serial sections. So it's a fairly involved process. Nevertheless, I wanted to point out that these parvalbumin cells are very, very small. You see this at the end of the arrows. There are not many of them. There are only a few % of the total neurons in this area, but they're very powerful cells. And you can also appreciate that there is fewer of these cells in the Tourette's brain, both in the head and in the body. But as I said, the head had a more pronounced decrease. So the next question was, there's so few of them, maybe all neurons are decreased. So this is only an epiphenomenon of the fact that there is a general decreased loss of neurons in this region. So we looked at total neuron density, and we found no differences in the head, but a small, actually moderate difference in the body. So it suggests that actually the area where we found the most pronounced decrease was not affected in terms of total neuron number. And when we looked at the proportion of parvalbumin neurons in the codec with respect to total neurons, so we calculated the percentage of cells, you see how few they are. They're only between 3 and 0.5% of the total cells. Well, we saw a strong decrease in Tourette's, but in the head, but not in the body of the caudate. So the conclusion up to now is that parvalbumin neurons, at least in these 4 patients with Tourette's, they have actually severe Tourette's, this particular group of patients. The kind of patients that do not typically improve with time, with age. So it's more marked in the caudate than in the putamen, and within the caudate, the parvalbumin neurons are markedly decreased in the head and not in the body. And it's not explained by a loss of total neurons. Then we asked, there are 4 kinds of interneurons that regulate the striatum, the excitability within the striatum. What about the others? So we looked at the cholinergic cells. The cholinergic cells are these very big neurons, the ones that are marked by an arrowhead, and they contain 2 molecules that we can use to identify. One is calretinin, but calretinin is also expressed in this other type of small interneurons. I'm sorry, the arrow are the big one, and the arrowhead are the small. So with calretinin, we could identify 2 subsets, the cholinergic big cells and the interneuron that are small. The interneurons have GABA, and these have acetylcholine. And when we looked, and then, of course, we looked at directly at cholinergic neurons using choline acetyltransferase, which is the enzyme that synthesizes acetylcholine. And here you can only see, of course, the big cells. And we saw a decrease in Tourette syndrome in both cases. So in the first case, when we looked at calretinin large-sized neurons, the small size are not affected, but the large size, the cholinergic cells are decreased, 52%. And this is in the caudate overall, and more so in the head than in the body. Maybe this will turn out to be significant if we have more patients, but until now, the overlapping is so that it's not statistically significant, but in the head it is. And also the cholinergic neurons in the head, but not in the body, were also decreased. So we're fairly convinced that at least in this small group of patients, there is a decrease in cholinergic neurons. And these neurons are very important, as I will discuss a little bit later. Again, the proportion of cholinergic neurons, the large size calretinin neurons, is decreased. Proportion of total neurons is decreased in the head, but not in the body of Tourette's. The large size cholinergic neurons that are detected by calretinin, they are also increased in the rostral putamen, and you can see them here, small one, big one, and this does not correspond to a change in cholinergic neurons detected by choline acetyltransferase. But I think it's probably because we don't have enough number of patients and there is some variability. So I think that if we examine more patients, this is going to be is going to turn out to be significant, because it's actually in proportion quite a large decrease. Also, there is a decrease in large size neurons also in the nucleus accumbens. So these large size cholinergic cells are probably going to be strongly affected in these patients. So next we wanted to make sure that this is a selective change. And as you saw before, these interneurons are only a small part of the cells in this region. 95% of the neurons are the medium spiny neurons. These are the projection neurons that go from the striatum to the globus pallidus. We stain them using DART32, a dopamine and cyclic AMP regulated phosphoprotein, that's the name of this. Using a monoclonal antibody, you can see how many of these cells are there in the striatum. We saw qualitatively no substantial difference, and quantitatively also could not detect any significant difference, although there is some variability, and we still are examining. We still have to finish this data and examine the whole sets of brains that we have. But up to now, there doesn't seem to be, either in the caudate, the anterior or slightly more posterior region of the caudate, no significant difference in this marker for medium spiny neurons. So in summary, what we saw was a combined large loss of cholinergic and parvalbumin positive interneurons. These secrete acetylcholine and these have GABA in the caudate head. The cholinergic neurons are also decreased in the rostral putamen and in the nucleus accumbens. We have no change in the small type of carotene interneurons, medium spiny neurons, or glial cells. So what does this mean? That's the big question. So here you see in different colors the type of interneurons in the striatum. Parvalbumin in green, cholinergic in red, and these other type of interneurons in yellow. They also are GABAergic, and so far we haven't examined them. What the parvalbumin do, they are right here. They receive both from cortex and from the cholinergic neurons. So these two systems are strongly interconnected with one another. The cholinergic neurons receive from thalamus and substantia nigra. So what these neurons do, they integrate information from cortex and thalamus and deliver that to the medium spiny neurons. And because they're inhibitory, these cells, strongly inhibitory, powerful inhibitory cells, they tend to decrease the input of the cortex and thalamus, and so they modulate cortical information. They keep the basal ganglia relatively silent. And you can imagine that if these cells are decreased and these cells are also decreased, this may increase excitability within the basal ganglia and also change the pattern of responsiveness of the striatum to the stimulation of the cortex and the thalamus. So, considering the fact that there is this different localization of the defects, that the head of the caudate is more affected than the body, and the head receives information from prefrontal cortex, which is the area of the cortex that is the site of executive function, as Dr. Plessen will tell you, basically has an important role in regulating our decisions and the way we decide to do one thing versus another. Well, if this information from prefrontal cortex is disrupted because the circuitry is abnormal, because we're missing these neurons, well, maybe people may have a hard time to decide or to regulate in time psychomotor movements and thoughts as well. That is probably not confined to movements per se, but also involved other aspects of our behavior. So that's the way we conceptualize this finding. And again, to summarize, we see a decrease in these cells here, and maybe a disconnection, relative disconnection between cortex and striatum. Difficulty of the cortex to regulate the function of the basal ganglia. So that perhaps may lead to an overactivity of the direct pathway, which will inhibit the GPI, which in turn will cause an overactivation of the thalamus and the cortex. More difficult to explain the other aspect, which was the increase in GPI neurons, which I alluded at the beginning of my talk. This could probably be maybe a compensatory phenomenon, because of course if these cells are increased, then you can imagine that this will tend to decrease the action of the thalamus. So I just also want to point out that there are possible sources of bias in our analysis. First of all, we have only a small number of brain samples. There always could be in this type of studies effects due to postmortem interval or the way the patients died that may have an effect on what we actually can detect. Also, all the patients were on different types of medications, and there are always age differences, although our patients were all pretty much in the age between 40 and 60. But nevertheless, there could be possible interferences. In terms of the etiology, why we have these changes? Well, there could be developmental changes in neuron number due to alterations in their generation, in their migration, or maybe they died. We know that one of the factors that can affect the etiology of Tourette's is perinatal hypoxia, and parvalbumin neurons and cholinergic, particularly parvalbumin neurons, are very sensitive to hypoxic insults. Also, there could be a fail to maintain the neuronal phenotype, or it could be, as I alluded to, environmentally induced. The other interesting thing to consider is that these neurons, all the inhibitory cells, including the cholinergic cells, are originally born in the basal ganglia and they migrate to different regions. So there could be defects in their migration that can explain what we detected. So finally, I want to acknowledge the people that collaborated in this work. These are the two postdocs that did all the analysis, and also Paul Kalaniti, who is a medical student who is not listed here due to my mistake, I guess. And then both Heidi Grants and Jim Leckman did a lot of work in the clinical phenotyping of the patients, retrospective clinical phenotyping. And Mike Schwartz, Cliff Saper, and Marian Di Figlia contributed to the analytical aspects of this work. Thank you. How do we stand with time? Do you want to? Maybe we can have time for one question, if there is one question, and then we'll move to Paul because we're actually a little bit short of time. Yes.
Could you comment on pandas in the etiology of Tourette and your findings?
So the question was about pandas. Disorders of immunological function related to streptococcal infection. It's another important theory in the possible etiology and pathogenesis of Tourette's. It's hard at the moment to put a link between pandas and this type of finding, but if you have a chronic inflammatory state in the basal ganglia with local release of cytokines due to inflammation, you can also imagine that could secondarily cause death of neurons. So that's one possibility. And I'd like to introduce Paul Lombroso, who is going to be talking about translational neuroscience, blocking the induction of repetitive movement.